All right. Well, good afternoon, everybody. Thank you for joining us today. Because this is only a 30-minute webinar, I'm going to keep introductions short. But my name is Jonathan Leung. I'm a psychiatric pharmacist that works in a clozapine and long-acting injectable clinic at Mayo Clinic in Rochester, Minnesota. I'm pleased to introduce Dr. Georgios Schoretsanitis today, who joins us from Zurich, Switzerland. Dr. Schoretsanitis was the lead author of a joint consensus statement published in 2020 titled Blood Levels to Optimize Antipsychotic Treatment in Clinical Practice. The presentation today will relate to antipsychotic TDM and was chosen based on the numerous questions received from previous virtual product theaters related to TDM and LAIs. As a reminder, please be sure to use the chat to ask questions as the presentation progresses, and we'll get to these at the end of the presentation. Any questions that we don't get to answer today will be sent out with a link and an announcement of an upcoming virtual product theater. Thank you, Dr. Schoretsanitis. The floor is yours.
Thanks for the kind introduction, Jonathan. I hope everybody can hear me. It's a particular privilege and pleasure for me to be here today, hosted by the American Association of Psychiatric Pharmacists. And this is because I think that your contribution to optimizing and enhancing safety and effectiveness outcomes for the prescription of psychotropic agents and specifically antipsychotics is vital. I'll be talking about the use of blood levels in clinical routine as part of strategies to switch or on the long term with long-acting injectables, long-acting injectable antipsychotics, baselining, but also managing non-trough situations, which reflect a very common challenge in clinical routine. These are my conflict of interests. And this is an overview of what you will be hearing in the next minutes. I'll be talking a little bit about the basic principles of therapeutic drug monitoring, aka measuring plasma or serum levels of the prescribed psychotropic agents, also abbreviated as TDM. And I'll be talking about TDM for antipsychotics specifically. And then in the end, I'll be taking a minute to talk about TDM for long-acting injectable antipsychotics. So when we're talking about measuring levels in everyday clinical practice, it's important to keep in mind what happens in the body of our patients when we prescribe medications and specifically antipsychotics. So it takes up to 5 times the half-life of the medication that we prescribe till some kind of balance or equilibrium between the amount of the drug that enters the body and the amount of the drug that gets eliminated is reached. So this is called steady state. And as I said before, steady state is reached after 5 times the half-life of the medication that we prescribe. Now, every time we measure levels, we are actually measuring the minimum value, which is also known as trough level. The trough level is right before the next intake of the medication. And here is the very next challenge that we have in clinical routine. And this is because when we're having somebody prescribed a medication at bedtime once daily, then it's already some kind of a challenge to get levels right before the medication intake, because this is in the evening or in the night, where the majority of settings may have trouble to get levels drawn. So what's important in this kind of situations is to keep in mind that, let's say we are not measuring right before the intake, like the example that I just mentioned, it's important to know that the level we will get back is going to be higher than the trough level, which is important once we're considering going high with the dose or going low. And what's even more important, and I cannot stress this enough, is to be consistent. This means that if we're trying to compare somebody's levels with the measurement done a month or a week ago, it's important to make sure that the time point is as close as it gets to the previous measure, because then it's this is how comparable these results are. Now, every time we increase or we decrease the antipsychotic daily dose, this happens again. It takes again 5 times the half-life of the medication that we prescribe till we get steady state. And as I said, whereas somebody can actually think about it, is medication with a longer half-life requires longer till steady state is reached, and medication with a shorter half-life requires less time to reach steady state. Now, it's a little bit different when we're talking about long-acting injectable antipsychotics, because here the trough levels don't necessarily depend on the time of the day, but it's important that the trough here is right before the next injection. What is nevertheless identical is the notion of the therapeutic reference range. The therapeutic reference range refers to a therapeutic window, to a range that consists of a lower threshold below which we expect a limited or a reduced effectiveness of the prescribed medication, but also an upper threshold of the therapeutic reference range, above which we do not expect any additional clinical benefit, and in fact, we may have increased risk of side effects. There is also the laboratory alert level, which is invariable twice the upper threshold of the therapeutic reference range, above which clinicians need to be particularly vigilant for the risk of side effects. Again, I'm summarizing three basic principles: trough levels, steady state, 5 times after the half-life of the medication we prescribed, and the therapeutic reference range with the lower and the upper threshold. Now, this is how it looks like in clinical routine. Once you want to measure levels, you need an indication. It's a problem-solving tool. Then once you have the indication, obviously you need to make sure you have the laboratory and ideally the pharmacological advice to interpret the results you're getting back. You need to have the demographic data, the diagnosis, the medication, and in fact the co-medication, as some of the co-medications that we have may induce or inhibit the metabolism of the medications we prescribe, and the clinical information. That's so important. I cannot stress this enough. Don't forget, we treat the patient, we don't treat the levels. Now, an indication may be routine monitoring, such as dose titration or reduction, and then also in the long term, in the maintenance treatment for relapse prevention. But it can also be a specific problem. The patient is not responding despite being prescribed standard dosages, um, managing side effects, adverse drug reactions, and also suspected drug-drug interactions, which are very common as long as we're prescribing multiple medications in our patients. Now, once we draw levels, it's important to make sure that the patient is at steady state, and we're talking about trough levels, although, as I said before, we need to acknowledge very specific practical challenges. So in this kind of situation, we also need to be consistent regarding the time point where we draw levels. Once we do have the laboratory that will do the assessment for us, we get the levels back, and that's the moment of truth. Now, based on the levels and within the concept and the context of the clinical response or the management of the side effect we're treating, we need to make a decision. What do we want to do with the dose? Do we going to go high? Do we going to low? Do we going to continue or even change the medication? And that's not the end. In fact, it's actually introducing a loop that goes on and on and on until the original indication that led us to prescribe TDM is satisfied. I'm not going to talk so much about lithium, but this is, somehow the vision for everybody who is so fascinated about TDM, just like me. For lithium, we don't just have a very well-established therapeutic reference range, but we do have this kind of data, robust clinical data, that allows us to personalize and individualize the lithium dose and lithium-based therapy, also based on the psychopathological ratings. So for example, for patients having predominantly manic symptoms, we want to go higher, targeting a range between 0.6 and 1 millimole per liter. But if we're having somebody with predominantly depressive symptoms in the prophylactic treatment with lithium, we target lower levels around or between 0.4 and 0.8 millimole per liter. Some more specific indications for TDM, including the assessment of adherence, which is a major confounders for safety and effectiveness outcomes in the prescription of antipsychotics, the lack of response despite being prescribed standard dosages, preventing relapse, managing side effects, adverse drug reactions. And what I really consider really important is the baselining. Once the patient is responding to medication and tolerating it well, it's the right moment to have a couple of measures of levels to define the patient's own personalized therapeutic reference range. It's this patient's own personal range where he responds and tolerates the medication well. Some additional indications for TDM include suspected drug-drug interactions, not just the medications that we prescribe, but frequently medications over the counter, counterfeit, and switching between generic forms, genetic abnormalities, and with that I'm referring to rapid, ultra-rapid, or poor metabolizers with regard to the activity of liver isoenzymes, obese patients, differential ethnicity, particularly vulnerable patient subgroups, including pregnant and lactating women, elderly, children, where TDM was originally introduced, but also patients with intellectual disabilities and forensic cases with a different rationale. And last but not least, patients with severe physical comorbidities that can affect the bioavailability of the medications that we prescribe. For example, patients with hepatic or renal insufficient cardiovascular diseases, chronic or acute inflammation, just like infections, and bariatric operations. And this is how it should look like when we're talking about measuring levels for long-acting injectables. So in the majority of the cases, we suggest to establish responsiveness to an oral antipsychotic. So right at the moment where the patient is actually tolerating the medication well and is responding to the antipsychotic prescribed, it's the moment to define the patient's personal reference range, as I said before. So that's the right moment to have a couple of measures as baseline that will help us as a compass when switching to the long-acting injectable counterpart of the medication. Now, once we start with the first injection, right before the next injection, we measure again the levels and we estimate the difference in the levels that has been created after adding the long-acting injectable in the therapeutic regimen. So based on this change in the levels, we can divide the change in the levels with several factors that I will be showing afterwards to estimate the oral daily dose of the antipsychotic that we need to reduce to account for the difference. And this goes on and on after every long-acting injectable until there is no more oral daily dose to be discontinued, but not just during the titration or during the introduction of a long-acting injectable, but also in the long run. In the maintenance treatment with long-acting injectables, once we want to adjust the dose, we can use again the levels to help us make the switch or make the dose adjustment as smooth as possible. I will now be talking a little bit about TDM and antipsychotics specifically. And as I said before, one of the most common indications for measuring levels for antipsychotics is actually the assessment of adherence, which is a major confounder for safety and effectiveness outcomes in clinical everyday life. So that's a really beautiful study done in a New York hospital back in the days, where clinicians measured levels in patients admitted for psychotic relapse in an emergency setting. So you're having patients admitted due to psychotic relapse, and they are taking or they are being prescribed antipsychotics, and clinicians are measuring the levels of these antipsychotics in the emergency setting. And this is what happened in the majority of the cases. In 2 out of 3 patients, patients had subtherapeutic levels. In other words, they were not taking the meds or they were underdosed. So I'm actually wondering how much or how many of these psychotic relapses could have been prevented if clinicians had been measuring levels regularly to ensure adherence and correct dosing. Now, drug-drug interactions is another very common scenario to measure levels in clinical routine. This is from our own data set. We looked into patients medicated, prescribed risperidone. We had a group being prescribed risperidone monotherapy and 3 groups being prescribed several different mood stabilizers as add-on, valproate, lamotrigine, and carbamazepine. Now, just a quick thing, when we're talking about risperidone levels in clinical practice, we refer to risperidone as a parent compound, but also its metabolite, 9-hydroxyrisperidone, also known as paliperidone. Just because both of them are pharmacologically active, they are clinically relevant. So when we're measuring levels of risperidone in clinical routine, we're actually measuring both of them and ultimately the sum of them, which is known as active moiety. So please keep in mind that these 4 groups did not differ regarding the daily risperidone dose. But see what happens when we look into the active moiety. They're having half or a little bit more than the half of active moiety. Why is that? This is because carbamazepine is a notorious pan inducer, in other words, accelerating the metabolism of risperidone and obviously seriously reducing its clinical effectiveness. So if you want to go for combination or augmentation strategies, you can do that, but TDM can give you some valuable insight which of these ones are to be avoided. And when we're talking about drug-drug interactions, it's not just about the medications that we prescribed. Um, the majority of our patients are coming to us with medications that they have from other disciplines. We previously looked into women medicated with prescribed clozapine, and we looked into women being prescribed or receiving contraception, oral contraception. We came up with in this very small cohort with a dose correction factor of around 0.5, which practically means that if you want to add oral contraceptives to clozapine in women, you may want to go for the half of the clozapine dose to avoid overdose. This is because oral contraceptives containing ethinylestradiol inhibit the activity of the cytochrome 1A2, which is the major metabolic pathway of clozapine. And in order to avoid clozapine overdose, you need to adjust the dose. And if we're talking about drug-drug interactions, the most common agent involved in drug-drug interactions is not even a drug, it's smoking. So this is a patient published 2 years ago in the Netherlands that decided to move from smoking regular tobacco to electronic cigarettes. Now remember, when we're talking about the inducing effects of cigarettes, it's not about nicotine, but it's about polyaromatic derivatives that are produced during tobacco smoking. Once you switch to electronic cigarettes, you don't have this inducing effects anymore. So look what happened here. The patient is smoking regular tobacco, has 400 milligram a day and rather low subtherapeutic clozapine levels. All of a sudden, he decides to move to e-cigarettes and the levels explode, although the clozapine daily dose remained the same. Consequently, the patient developed tiredness, hypersalivation, obstipation, and EPS. And the clinicians had to cut the dose to 300 milligram a day, with clozapine levels now being within the therapeutic reference range of clozapine, and the clinical symptoms getting better. In other words, the adverse drug reactions were remitting. And it's not just about drug-drug interactions and adherence. Is also a very important issue of the clinical response, the so-called point of utility. And I want to elaborate about this in a minute. We looked into patients treated with risperidone. I'm now moving to risperidone in a large naturalistic sample. And we looked into the levels, comparing them between non-responders and responders. So if we draw a line around 60 nanogram per milliliter, look what happens here. In the responders, there was just one single individual above this line, where there were multiple patients above this line with levels above this line in the non-responders group. In other words, this introduces the notion of the point of utility. Once you cross this line, it doesn't make any sense anymore. It's worthless. Keep increasing the risperidone daily dose, as it is unlikely that the patient will respond. And this perfectly coincides with the upper threshold of the therapeutic reference range, which is 60 nanogram per milliliter. Once you've done that and you know that this patient is not going to respond and is not going to respond anymore, you can consider alternative strategies like augmenting risperidone with another medication or switching to another antipsychotic. I'll now talk a little bit about clozapine, where we do have the best type of TDM evidence. The majority of the guidelines worldwide, including the Canadian, where I'm taking this as an example, suggest measuring clozapine levels when assessing effectiveness of clozapine, which is a lower threshold of 350 nanogram per milliliter. But even before introducing clozapine, which in the majority of the cases meaning before establishing a treatment-resistant schizophrenia, TDM has a role. In other words, TDM can help to exclude pseudo treatment-resistant schizophrenia. And this is because many of these cases are actually due to a lack of adherence. So TDM does have a role before even introducing clozapine. This is from a worldwide known consortium that previously suggested measuring levels at least on one occasion to assess treatment resistance. In other words, setting the indication for clozapine. And just going back to the lower threshold of the therapeutic reference range of clozapine, a beautiful meta-analysis 2 years ago from Dan Siskett and colleagues pointed out that patients with levels of clozapine above 350 nanogram per milliliter had 2.3 probability or likelihood, increased likelihood to respond to clozapine compared to patients with clozapine levels below 350 nanogram milliliter, which is massive. And this explains why there is a consensus regarding this lower threshold of the therapeutic reference range. Talking about clozapine and safety, clozapine is notoriously famous for side effects. We looked into our own data set with regard to hypersalivation, which is a very common type of side effects in clinical practice. And sometimes we underestimate its impact on the life quality of our patients. We looked into the levels of patients tolerating clozapine well compared to the levels of patients with hypersalivation due to clozapine. Now, let's just draw a line again at 600 nanogram per milliliter, which is the highest, is the upper threshold of clozapine therapeutic reference range. As you will notice, the majority of the patients tolerating clozapine well had levels below this line, whereas around almost the half of the patients, actually a little bit less in the group of patients with hypersalivation, had levels above this value. And this difference gets even more striking if we draw a line at 1000 nanogram per milliliter, which is the laboratory alert level for clozapine, where we only had one single individual out of 323 patients tolerating clozapine well versus 9 patients with hypersalivation out of 72 in total. So again, when we are managing hypersalivations or when we're trying to prevent it, measuring levels can be particularly helpful. And not just about hypersalivation, a previous systematic review in a very small number of patients, but very strong correlation between these astronomical levels of clozapine in patients with seizures. So in patients with clozapine-induced seizures, all of them had levels that were way above the laboratory alert level, 1,300, way to twice as high as the laboratory alert level. And this is why several guidelines worldwide suggest the prescription, the prophylactic prescription of anticonvulsants in clozapine-treated patients that have clozapine blood levels that high. I'll be talking about that in a minute. Now we use this the available clozapine data trying to create an algorithm to adjust the dose for clozapine using as a main information the clozapine blood levels, but also the clinical symptoms. So in the first scenario, when you're having somebody whose clozapine blood levels are below 350 nanogram per milliliter, in other words, subtherapeutic, if the patient is not responding well, is not tolerating clozapine well, You need to treat the adverse drug reactions, but also try to go high with the dose slowly, aiming for the reference range. If the patient is not responding but is tolerating clozapine well, you want to go high, aiming to reach the reference range. If response is good, but the patient does not tolerate clozapine well, you need to consider go low. And if in the ideal scenario, the patient is tolerating clozapine well and responding to clozapine, you just go on and continue to monitor. Now, in the scenario where the patient's levels are within the range 350 to 600 nanogram per milliliter, if the patient is not responding and not tolerating clozapine well, you're going to go a little bit slow high with a dose, trying to remain within the range, but keeping an eye on tolerability aspects. If the patient is not responding to clozapine and is tolerating clozapine well, then you need to go high, trying, however, to remain within the reference range. If the patient is responding but not tolerating clozapine, you need to go down. If tolerability does not improve, aiming to remain within the range. And then again, the ideal scenario where the patient is responding and tolerating clozapine well, just go on to monitor. Now, one of the trickiest scenario when you have patients with levels above 600 nanogram per milliliter, the patient is not responding, is not tolerating clozapine well. In this kind of scenario, you need to go down with the dose. And again, if you're having clozapine levels, astronomic clozapine levels, like around or above 1,000 nanogram per milliliter, you need to consider prescribing anticonvulsants given the risk of seizures, as I mentioned before. If the patient is not responding and tolerability is okay, again, you don't go higher with the dosage anymore. You need to consider augmentation or prophylactic anticonvulsant prescription. And in case where the response is good, but the patient is not tolerating clozapine well, you go down slowly, trying to get within the range. In the scenario where the patient is tolerating clozapine well and responding well, you just monitor, but you need to be particularly vigilant for the risk of side effects, including seizures, in which case we need to consider to prophylactically prescribe anticonvulsants. I'll now move to talk about specifically the use of TDM for long-acting injectables in clinical routine. Long-acting injectables are gaining in role in clinical routine. This pharmacoepidemiological data is coming from Belgium, showing us that long-acting injectable second generations are slowly replacing the first generation, which is a little bit the pattern that we previously observed for the oral antipsychotics as well. But we also expect a way more dominating role for long-acting injectables in clinical routine as time goes by. I showed this slide before. This is how to use TDM, measuring levels for LAIs when you're switching from oral counterparts to the long-acting injectables. As I said before, we aim for oral responsiveness, and then we establish the patient's personal therapeutic reference range. Now, once we introduce the injection, we measure the difference in the levels after the injection, and based on this change, we can adjust the dose. I'll use a practical example to show how this is done. These are the oral dose adjustment factors for the second generation antipsychotics, aripiprazole, olanzapine, polyperidone, and risperidone. For the last one is 7. Just keep this in mind for a minute. Magic number 7 for risperidone. Let's say we have somebody with baseline responsiveness to oral risperidone, 4 milligram daily dose that leads to a blood level of 31 nanogram per milliliter at steady state trough levels. Now, the next thing is we introduce the injection. We decided with our patient to move on to risperidone consta, risperidone microspheres. After 2 weeks, 50 milligram injection, we measure the levels. Again, we now have a 44 nanogram per milliliter. This is actually a real case from my own data set. The next thing we do is we measure the change in the levels, which is 44 minus 31. It's 13 nanogram per milliliter. And we divide this again with magic number 7. And this makes rounds up to 2 milligram a day. So now from 4 milligram a day minus 2, the new dose needs to be 2 milligram a day. And this ensures a switch transition from oral to long-acting injectable counterparts. Just a couple of more slides on long-acting injectables and the use of levels. I recall the days where polyperidone palmitate was first introduced in the market, where in the package insert I was reading about the apparent steady state. It was claimed that you just need 1-2 injections, no oral substitution, and the patient reaches apparent. It's not real, again, it's apparent steady state right afterwards. Now, in the meantime, we now do have long-term or longitudinal TDM data that points out that for some of the patients, the levels keep increasing and increasing, and actually the real steady state is reached after around 9 months or something. So in the long term, in the maintenance treatment with paliperidone palmitate, it's important to keep measuring to make sure that the medication is not accumulated or is not reaching levels that could get toxic for the patient. This is a rather difficult to read list. I would just, we recently published a list of expected steady state trough blood levels. These are levels that we expect patients treated with aripiprazole once monthly, 2-month Lorexil, olanzapine palmate, and all the second generation LAIs. So these are the levels that we expect these patients to reach at steady state in trough. And that's important because once you have a patient has levels that severely deviate or are far away from these levels, you need to ask yourself, why is this happening? Is this because something is interfering with the metabolism of the long-acting injectable? Is this because there's an absorption issue? It's unclear, but at least you do have some hints of what do you expect to see in a patient at steady state, in other words, in the long term, in the maintenance treatment with long-acting injectables. I want to show 1 or 2 more examples of how measuring levels can help the maintenance of the long-term treatment with LAIs. Liver impairment, we systematically reviewed studies earlier on risperidone microspheres, risperidone constant, and TDM, and we estimated the ratio of risperidone parent compound and active metabolite as an index of bioavailability of risperidone in this patient. And look what happens. In all these studies, the highest risperidone divided by 9-hydroxyrisperidone ratio was estimated in a study done by Green early in the days in patients with alcohol use disorder, where we expected serious liver deficits. In other words, different patterns of bioavailability. And these are the kind of patients that you want to avoid accumulation of the medication when you're prescribing a long-acting injectable. Another very interesting example is a case report from France back in the days. A 47-year-old female with an end-stage renal failure treated with 75 milligram once monthly paliperidone palmitate, where clinicians measured levels over the first 5 months of paliperidone palmitate, and they published the levels of paliperidone in the blood. And if you use these concentrations divided by the dose of paliperidone palmitate, you estimate a C divided by D ratio around 20. Keep this number in mind, because what we did is we systematically reviewed paliperidone palmitate TDM studies, and we came up with a CD constant, the CD ratio around 7. So if you compare this number 7 with the 20 that we estimated in the case report shown before, you understand that you have a bioavailability increased at least by 3. And I wonder what happens in the long term in a patient like that. Ultimately, I think it's just important to keep in mind that measuring levels can be an important part of a patient's journey, not in every phase, but in some of the really important phases. In the beginning, symptoms identified, going on with the diagnostic process. And ultimately, when you're discussing treatment choices, the use of levels can be a part of a shared decision-making process that can enable a smooth decision, a smooth process during therapy cycles and regime changes, and ultimately to improve and support recovery. And this is how it looks like in the end. We're a group of professionals that are assisting our patients within this journey, and we consider measuring levels as an essential part of this process. Thank you so much for your attention, and I apologize if any sounds from the background were interfering with my talk.
Excellent. Well, great. Thank you so much, Dr. Schoretsanitis. Again, if you have any questions, feel free to put those into the Q&A section within Zoom. We had one come in. Dr. Schoretsanitis, maybe you can comment on this as it relates to classifying or conceptualizing toxic range versus supratherapeutic, and how you might consider toxicity to equate to these levels, or where you conceptualize that.
Sure. If it's okay, I'm going to share again my screen for a second, because I think it will help to make this even more clear. I think I talked a little bit about that when I showed the notion, when I presented the notion of therapeutic reference range. So the difference is mainly here. Me as a clinician in my everyday clinical practice, I wouldn't be so unhappy if the patient's levels are somewhere here, so they're above the upper range. But what I really get worried is once patient's levels are getting here in the toxic range, and this is because here we have a different type of risk pattern. This is the type of situation where tolerability is way different from this range. Obviously, this is different between different individuals, but as a rule of thumb, I will get way more concerned and worried having somebody here, and I would consider I would monitor way more frequently if I had somebody with whose levels would be moving around here, instead of having somebody who has levels above the upper threshold of the therapeutic reference range.
Great.
Does this answer the question?
Yeah, I think that's excellent. And then one actually came in related, not maybe specific to TDM, but if you're checking you're doing TDM, there's side effects that correlate, and that level is in that toxic range. How do you deal with that if somebody's on a long-acting intramuscular injectable?
Oh, well, that's a really tricky situation. Thank you. That's the real challenge. I've seen different types of solutions in that. There was actually a couple of years ago, there was a beautiful case report published in the American Journal of Psychiatry where people were prescribing carbamazepine as an inducer to accelerate the elimination of risperidone. That was a case where somebody was developing side effects. I think it was a severe EPS due to risperidone constant. I remember that. Authors were actually suggesting carbamazepine as a solution or as a treatment, which is in terms of pharmacokinetics, it's a really brilliant idea. Now prescribing carbamazepine to somebody goes with other risks, so I cannot think of it as a mainstay treatment options, but I can think it as an interesting idea. Now, if somebody is having severe side effects to a long-acting injectable, obviously symptomatic treatment would be a first way to go if this is persisting. The only way to get it out of somebody's body, it would actually be an inducer, because it's way different than when you're having oral antipsychotics. You just discontinue them, right? But that's not the case if you're prescribing long-acting injectables. And I think that we will need to come up with better solutions, as these medications are really getting increasing attention and role in clinical practice. And this is where I consider TDM measuring levels as a really important monitoring instrument.
Excellent, great. Yes, that was an interesting case report, and definitely interesting pharmacokinetic maneuver. Some practical questions. I think this comes up a lot as well, even for clozapine TDM, which might be, better established in clinical practice. One question that came in is turnaround time. So in your practice, how long do these maybe antipsychotic levels that aren't traditionally done, maybe more broadly, how long do those take to come back? And what kind of, future direction might you see that might improve that turnaround time, or, future directions of TDM or the gaps?
Right. Well, I think that's a major issue that we cannot ignore. So, for example, in my case, I'm getting the results back within 24 hours, and um, I think that if this is not the case, if you're not getting the results back, the TDM findings back within a day, it's actually hard to use them. It's not useful anymore, because if I heard stories of people that get results back like within 10 days or something like that. And I think that if you are getting these results, if you're getting the results back within a days, it's not useful anymore. It's more than, it's more like an academic information as a proof of concept of what the clinician thought at the first place. The thing is that the challenges that we're facing in everyday clinical life demand a solution right now, and so we need to act now. We cannot just keep waiting. I think I was discussing with somebody recently, like, you're having a chest pain, you cannot just like go to a cardiologist and you're going to tell you, okay, I'll send you the ECG findings within the next 2 weeks. It doesn't work like that. It's an emergency situation. I need the information and I read it now. If it's not going to be now, it needs to be within the next 24 hours. Otherwise, it's not useful. Um, and this is where, like, there's this new, we expect so much of technology, this new technologies with the point of care, devices that allow us to get the results within, like 3 minutes. This is an absolute game changer, because this is when it gets to help us to make decisions. It helps us essentially to make decisions that treat patients, that manage side effects, that you can prevent the relapse, you can help somebody go through a psychotic relapse. And all these kind of situations require urgent action. We cannot wait 2 days or 10 days or 2 weeks. It's not useful anymore. It's more of an academic interest if results are coming back within 2 weeks.
Right. Certainly a challenge that we had at our institution. We were able to advocate, for getting our clozapine levels back a little bit sooner. And so working with the lab folks. So, as pharmacists, we definitely also can advocate for some of these technologies or strategies, or see if the lab is able to turn those around a little more quickly.
Joe, can I
Beyond.
just one
Yeah.
short thing on that? That's important for me. The other thing is, my experience is that if you're getting the results for clozapine, specifically for clozapine, if you're getting them shortly back, I think that it also decreases the willingness of clinicians to discontinue clozapine, because if you're having the safety that I will get these results fast as possible, and I'm not getting overtly concerned and worried about my patient, then I'm not gonna think of discontinuing clozapine as the first thing to do. And that's really important, because my experience with discontinuing clozapine in these patients is that I never get them back on the same functionality level once I discontinue clozapine. There's something about that. I don't know what it is. It's a phenomenon that has been described in literature. We don't know enough about it, but once you discontinue clozapine, it's so hard to get them back at the functional level, at the life quality level they were before. So I cannot stress enough how important it is to keep these patients on clozapine doing well, which wouldn't have happened with any other medication. Sorry for interrupting.
Yeah, no, absolutely agree, and excellent points. Clozapine's well established, but there was another question about, is it your suggestion that TDM of other antipsychotics should be more routinely implemented in practice?
So yeah, this is definitely the case, right? We do not have the same type of data for all antipsychotics, and for clozapine we do have very robust data. That's the most robust that it gets. Now, regarding other antipsychotics, and I'm just going to think a little bit about the second generation antipsychotics, as they are now being the main player in the field. And I think it's really important to keep monitoring. And one of the most common situation or scenario where I find myself is when I'm treating somebody with olanzapine and I'm prescribing the maximum daily dose approved by the FDA, which is 20 milligram a day. It happens to me so frequently that I have to go higher with the dose, and I'm practically going off label. So whenever I'm going off label, measuring the levels as regularly as it gets offers me some kind of safety, some of security that I'm doing something that ignores the FDA guidelines, but I do have serious hints why I'm doing that, right? So I'm having somebody who has a very low olanzapine level, and this is why I'm going higher than FDA suggests. And I think all this kind of, my experience is we always end up treating outliers. And in all these situations, I think that, it's very important to have these levels because it is a very essential part of good monitoring. And I think good monitoring in acute situations, and particularly in the long run, in the maintenance treatment, is an essential baseline, is an essential fundament of that.
Yep, excellent. And with that, we've run out of time, and thanks for everyone for sticking around a little bit longer through the Q&A. Great questions. If you still have questions, feel free to pop those into the Q&A before you head out. We'll be sure to get some answers circled back to you via a link that will be distributed. But with that, thank you so much, Dr. Schoretsanitis, for this presentation and insight to antipsychotic therapeutic drug monitoring.